Hi, everybody. My name is Brandon Williams, and I'm going to be going over considerations that need to be made for the management of cardiovascular disease in women. First, what is cardiovascular disease? It's an extremely broad term that encapsulates any condition that relates to the heart or the blood vessels within the circulatory system. Um, for this presentation, I'm going to be going over hypertension specifically because there are things that that affect women directly that have to do with hypertension. Hypertension is the increase in blood pressure. We see hypertension is declared when systolic reaches above 130 millimeters per mercury, and then diastolic reaches above 80 millimeters per mercury. This increase in blood pressure can occur from many things, such as smoking, stress, and specifically what I will go over here will be hormonal changes that have to do with estrogen. Subgroups of women that I think I need to identify. Um, Young women, they're at a lot less risk for primary hypertension, as opposed to hypertension that occurs from a different illness, such as Turner syndrome. This has to do with estrogen, as we'll talk later. And then elderly women, hypertension is extremely prevalent within this population. And this also has to do with estrogen, as we see estrogen levels are decreasing as the woman is reaching perimenopause and then postmenopause. There's just a graph going over what I just said. I see women here are a lot less likely to have hypertension at both stage one and stage two, but when they do have it, they also have a lot better control of it. There's a predisposition that women have. It's called the estrogen paradox. Estrogen or estradiol, specifically the 17 beta estradiol hormone, has been shown to interact with cardiomyocytes really well. So it is improving diastolic function as well as decreasing inflammation and hypertrophy within the heart, which are both things that can cause hypertension. Environmental factors that affect the sexes. These all have to do with stress. They all circle back to stress. Ones I want to point out on are education, employment, and routine place of healthcare. Education, both men and women who have a lower education status, that being um, below a college level education do have a higher likelihood of having hypertension. Employment, women who are unemployed seem to have a better control of their blood pressure. It's a correlation that isn't really understood, but is really prevalent, and it's not something that's also seen in men. Then a routine place of healthcare. Men and women who don't have a place in which they can go to in order to check up on their health seem to have a lot less control of their blood pressure. Uh, all these, like I said before, all of these have to relate to stress, but I think these three are the most important ones. Management of hypertension, non-pharmacological means are going to be a lot better or a lot more pushed forward than pharmacological means. Things like weight loss and sodium reduction are pretty standard and they are prevalent across both male and female. We see a positive correlation between a decrease in both body fat percentage and sodium intake, equating to a decrease in systolic pressure, as well as with alcohol consumption and blood pressure. Pharmacological means, we usually want to use these alongside non-pharmacological, um, but the medication is pretty universal. We don't really have anything that affects women directly except for one. So pharmacological means are usually going to be things like diuretics, ACE inhibitors, beta blockers, and vasodilators. And then why you should care. As you can tell from this presentation, we don't have a lot of things that help women directly, even though 90% of women above the age of 80 have hypertension. So I think we need to look into things that benefit women directly in both non-pharmacological means and pharmacological means, as well as just ways to reduce stress. As you can tell, stress is a major factor when it comes to the presence of hypertension. Thank you.